Welcome to the AlohaCare 2021 Pay for Performance program. Thanks so much for taking the time to learn more about AlohaCare's program. My name is Amy Feely-Austin. I'm the Director of Quality at AlohaCare, and I'm happy to share our 2021 program with you today. At the end of this session, the information will be repeated, but as we go along, please remember that if you have any questions about our program, you can feel free to connect with me at afeelyaustin@alohacare.org for HEDIS measure specific questions related to the HEDIS measures in our program or the way that you submit appropriate medical record documentation. You'll be reaching out to my colleague, Carrie Taylor, whose email is also listed here. Let me go through the AlohaCare P4P basics. This is a little bit of context about our P4P program. MedQuest funds its annual P4P program through financial withholds from each Quest integration plan. AlohaCare earns back withheld funds based on our plan level P4P performance. Our provider P4P program is funded using our earnback of these withheld dollars. Therefore, what we earn back from our aggregate quality scores goes back to providers to incentivize them for providing great care to our members. Our success depends on providers' success in closing patient gaps in care, which in turn increases our aggregate quality scores. This has been especially challenging in the years 2020 and 2021 due to the impact of the COVID-19 pandemic. To support provider success, we are providing measures early in the year. Although we do not yet have final guidance from MedQuest about their calculation of our withhold methodology. As such, you will see in our performance letters that our award calculation is subject to change later in the year. Our measures, however, will not change, so rest assured that any changes will be to weaken the methodology in favor of the providers. Our 2021 P4P goals. These are our quality goals and what we hope to achieve in offering this P4P program. Number one, we want to increase provider participation and satisfaction. Our continued improvement depends on an increased provider participation and satisfaction with our quality initiatives. We want you to be able to enjoy the partnership with AlohaCare and earn incentives from closing gaps in care, which will provide you with increased earning opportunity from our plan. Number two, we have been developing and investing in tools and resources to support providers, not only with P4P, but with population health overall. We have developed provider-friendly updates to the HEDIS Quick Reference Guide Manual, which you can see linked below on this webpage, and also Provider Scorecard app with interactive features and actionable quality data that lets you know who has gaps in care. These resources are available in your provider portal, and if you have questions or want a walkthrough of the apps to learn more about how they can be used, please reach out to one of us and we'd be happy to schedule time with you to walk through those tools. The third goal of our 2021 program is to improve member outcomes despite tough times. 2020 was certainly a tough year. Many members delayed preventative care due to COVID. Other availability of certain types of scanning and screening, such as breast cancer screening, was closed for a period of time, and so we saw a lot of quality measures decrease. We realize it's been very hard for people to know what to do and when to do it, and we understand that members getting their gaps in care closed is important for them to take that initiative on their own. Therefore, we have initiated the following actions as a plan. We are incentivizing members through targeted communication with financial awards tied to gap closure. We are texting, calling, and mailing reminders to members about needed care and driving them back to you, their PCP. And we are promoting vaccination for COVID, flu, and pediatric vaccination through community-wide and targeted messaging. Now, let's jump into the details of the program. First, our Medicaid measures. Childhood immunization status, which returns from last year. Well-child visits in the first 15 months of life, and well-child visits in the first 30 months of life, which are new measures from NCQA. We also have the well-child visit 3 to 21, which is a new measure from NCQA and replaces adolescent well care. Comprehensive diabetes care, A1C control, cervical cancer screening, prenatal and postpartum care for prenatal and postpartum as two separate measures. Next, we have our Medicare measures. First and foremost, the Medicare annual wellness visit. We include the functional status assessment, medication review, and pain assessment in this annual wellness visit. Secondly, colorectal cancer screening. We have the care of older adults measures with an award bonus if these 3 items are completed within the context of an annual wellness visit. But we will independently award funds for functional status assessment, medication review, and pain assessment. We have breast cancer screening, comprehensive diabetes care, A1C control, diabetic eye exam, and nephropathy screening. And finally, a new measure, patient engagement after inpatient discharge. I'm going to tell you about some changes to our 2021 P4P. We tried to keep our 2021 P4P as consistent as possible with prior year programs, but we do have some changes. First, our Medicaid P4P. The program now has 3 tiers. Providers are assigned to a tier based on criteria that includes historical performance, panel size, and capacity to improve. I'll tell you more about those tiers in a moment. A few measures have changed per NCQA guidelines, and this will be consistent with other programs you may be engaged with. All of our tiers offer higher payment for gaps closed using coding versus medical records due to the increased importance of coding and the year-over-year reduction of measures that allow medical records as evidence of compliance. Now on to our Medicare program. All of our tiers incentivize the Medicare annual wellness visit with a bonus payment over and above payments that are offered for individual completion of the care of older adults measures. All tiers offer higher payments for gaps closed through coding versus medical records. I'm going to offer the rationale for our revised model. This year, we're offering the same set of measures to all of our providers. The difference in tiers recognizes the differences in practice models. It addresses the needs of very small practices and CHCs whose scores can vary widely due to the small number of members in the denominators of certain measures. The new program works with the value-based payment models to simplify our VBP offerings. For example, our pay-for-performance scores are used to calculate distribution of shared savings for providers that are involved in a VBP model. This streamlines and simplifies our offerings. The new model challenges private practices who have a strong capacity to improve. It also engages providers wishing to participate in VBP. The first tier that I'm going to describe is the Tier 3 payment approach. You will know which tier you are in when you receive your pay-for-performance letter. If you have not received your pay-for-performance letter and want to know what tier you have been included in this year, please contact me at your earliest convenience. The Tier 3 payment methodology is the most straightforward payment methodology. For this model, you would earn a flat rate of payment for any measure for both Medicare and Medicaid where your compliant member rate is above 20%. The only difference in this model is that we have a slightly lower payment for measures that are closed with medical records than we do for payments for gaps closed with coding. You can see this in your letter. The Tier 1 and 2 methodologies are very similar. Both of these tiers use a rate gap closure methodology, which was previously used in the risk pool P4P that we offered to Hawaii's community health centers. The evaluation for every performance measure in these two tiers is going to be based on 3 data points: the current period rate, prior period rate, and current period target rates, which are national benchmarks. The rate gap is the difference between the measure's prior period rate and the current period target rate. Eligible incentive is based on the MQD 2021 incentive pool, which consists of a 1.25% withhold of our plan's premium. Both rate gap and payment methodologies require year-over-year improvements and are subject to MQD changes later in the year. This is the difference between Tier 1 and Tier 2. For Tier 1, there are 4 thresholds for payment. The top 2 thresholds are identical to the Tier 2 model. The third threshold offers practices opportunity to earn 35% of the eligible incentive for their attributed members, where the rate gap has been closed by 15 to 24.9%. The fourth threshold offers practices the opportunity to earn 20% of an eligible incentive for measures where the rate gap has been closed by 0 to 14.9%. This is the most challenging tier, but these practices will still receive payment for modest improvement. The Tier 2 model has 3 thresholds for payment. Like Tier 1, the top 2 thresholds are identical. The lowest threshold gives practices the opportunity to earn 35% of the eligible incentive for each measure where the rate gap has been closed by 0 to 24.9%. This encourages struggling practices and very small practices and CHCs to earn, even in cases of modest improvement. Now we'll talk about the MEDICARE program for Tier 1 and Tier 2. The MEDICARE program is identical for Tiers 1 and 2. In this model, AlohaCare will pay the noted incentive amount for each attributed and compliant member per incentivized measure where the compliance rate meets the minimum threshold. This minimum threshold is based on the national 25th percentile and is listed in the final column here, minimum threshold to earn payout. So these are the measures we spoke about earlier: the annual wellness visit, colorectal cancer screening, 3 care of older adults measures, breast cancer screening, 3 comprehensive diabetes care measures, and the patient engagement after discharge measure. All of the details here will be seen in your letter. Measures without baselines. As we mentioned earlier, there are 2 new measures, the W30 measures and the well child visit, which do not have baselines because we didn't record them last year. That's because they're new with NCQA. Fortunately, in these cases, we do have recorded data from claims that we can use to create baselines that will act as the prior year rate for calculation of P4P. The measurement specifications can be found in the 2021 Quality Measures Guide. Your next steps. You should have received or will soon receive a letter with program details and payment structure based on your tier assignment. Your gaps in care reports are still online in the provider portal, but the new provider scorecard has launched as well and is a great opportunity to look at your data and your scores and get interactive, actionable patient level data. Ask us about that if you have any questions. Please do check out our 2021 Quality Measures Guide for hints and tips to make coding and P4P earning easier. Please also feel free to reach out to myself or your provider service representative to schedule a live presentation or request for ad hoc custom support, including training on any of the new tools. Thank you so much for taking the time to watch the video today. Feel free to reach out to me directly at afeelyaustin@AlohaCare.org or reach out to your provider rep with questions. Again, for HEDIS measure-specific questions, please contact Carrie Taylor, RN, ctaylor@AlohaCare.org. All of this information and our contact material is in your letter as well. If you would like to see more, please click the links below. Thank you so much for your time.